And there you go. Perfect. Hi, everyone on Zoom and in person. I'm Elizabeth Zauber. I'm a movement disorder neurologist at Indiana University here in Indianapolis, and I lead our Parkinson's Foundation Center of Excellence, and I'm also involved in deep brain stimulation surgery, which is what I'm going to talk to you all about today. Just need to share my screen. Okay, looks like we are good to go. So I was originally asked to talk about focus ultrasound, but what I'm going to tell you towards the end of the talk is a little bit more about focus ultrasound for Parkinson's, but I still don't think it's replaced DBS, and I don't know if it's really ready for most patients. And so the bulk of the talk will focus on deep brain stimulation surgery with a little bit about focus ultrasound at the end. So the history of DBS, I think it's important for people to know that deep brain stimulation surgery has been around for a relatively long time now. In fact, surgery for movement disorders like Parkinson's started in the 1950s and 60s, mostly because we didn't have any real medicines at that time to treat movement disorders. And so surgeons started essentially poking around in the brain, trying to poke the right spot and help people. And then when medicines like carbidopa-levodopa came around for Parkinson's disease, there was a period of time where neurosurgeons weren't really doing any more surgeries. And then by 1991, DBS was approved for essential tremor, and then later in the 90s got approved for Parkinson's disease. And so when we think about what is deep brain stimulation surgery, this is some of the photos or pictures that patients have come up with as they imagine what deep brain stimulation surgery is. I guess many of you probably still remember when I lecture students, they're not old enough to remember Palm Pilots, but I think you all might remember Palm Pilots. So this person was using a Palm Pilot to mimic his implanted generator. This is his outfit he was wearing the day of surgery. And so this is kind of a patient's imagination of what DBS might be like, but this is probably a more accurate view. So I think probably most people are familiar with this general concept of DBS as an implanted. Takes a village. So I was saying this is probably a picture that many people are familiar with, where deep brain stimulation is a neurosurgical procedure to treat Parkinson's and other movement disorders, where a neurosurgeon implants a pacemaker-like device, which is this sort of wire that you're seeing at the bottom of the screen with the little black dots at the end. And then a battery pack goes in the chest, kind of under the collarbone area. And this is just showing one side of the brain, but the other side of the brain is usually treated as well because Parkinson's affects both sides of the body. If we look at the next slide, oh no, okay. There are multiple brain targets that can be used to treat movement disorders. In Parkinson's, the most common brain targets that are implanted are the subthalamic nucleus, which is there in green, which you can see is a fairly small target, and then the globus pallidus, which is in the dark blue, which is a larger brain target. And then yellow is the thalamus, which is typically used in essential tremor, and so just keep that in your mind for when we talk about focus ultrasound. I think the most important thing to remember when we're talking about deep brain stimulation surgery for Parkinson's disease is that there's two main reasons why we do it. The first reason is probably the easiest to understand, and that would be tremor. That's very bothersome to people and hasn't responded to medicine, either because medicines aren't well tolerated or the medicine hasn't been effective at reducing the tremor. This is not the majority of people who have DBS for Parkinson's. It's a smaller percentage of people who fall into this category, but I'm talking about it first because, as I mentioned, it's a little bit easier to understand because tremor is there, is not responding to medicine, and it will respond to DBS. Okay. The second but more common indication for deep brain stimulation surgery in Parkinson's is what we call motor fluctuations. So motor fluctuations mean someone is having a good response to their medicine. When the medicine's working, they feel almost normal, but that benefit of their medicine is not lasting long enough from one dose to the next, and may be accompanied by side effects like dyskinesia, which is involuntary movements. And so for these patients, the best predictor of how much the DBS is going to help them is how much does medicine help them. Because for these patients, the DBS won't make you better than the medicine makes you. It just gives you the benefit of the medicine over many more hours in the day. So that, again, is the tricky part that is sometimes hard to understand, that if medicine doesn't help at all, surgery is not going to help except for tremor. So when we're thinking about who's a good candidate, first thing we want to make sure is Parkinson's the right diagnosis? Maybe the person's struggling with symptoms because they've been misdiagnosed, and they haven't tried the right medicine combination yet, right? So has the right medicines been tried? Is the diagnosis correct? The second would be a disease duration more than 5 years. The reason for that is it's quite rare that Parkinson's disease would progress quickly enough in 5 years to warrant the risk of DBS. And if symptoms did progress that fast, that would be a red flag to us that this might be an atypical form of Parkinson's. And those atypical forms of Parkinson's, like multiple system atrophy, progressive supranuclear palsy, typically are not going to respond well to DBS. There is no absolute age maximum in this country. In some countries, 70 is an age cutoff. We know that the risk of surgical complication goes up as people get older. And in general, younger patients have more benefit from DBS, but there's no absolute maximum age cutoff. We try to look at each person individually, how healthy are they, and use that as a guide. And then we know Parkinson's causes motor symptoms as well as non-motor symptoms, right? So non-motor symptoms bring mood, cognitive changes, bowel and bladder changes, etc. And DBS is primarily a therapy designed to help the motor symptoms, not the non-motor symptoms. So we really want to know that it's the motor symptoms that's really causing someone the most problems with quality of life, because someone could have a lot of tremor, but what really bothers them is something else, some non-motor symptom, and then maybe DBS isn't right for them. And as I mentioned, the response to medicine is the best predictor of the response to DBS. So we like to see that there's at least a 30% improvement with medicine, but usually people who choose DBS have more like a 50% improvement with medicine. So what does DBS do? As I mentioned, it primarily treats the motor symptoms of Parkinson's disease, tremor, dyskinesia, and then off time. So now I'm going to show you a video of somebody who had DBS and was participating in a clinical trial of the DBS and is coming in with the stimulator on, and then as part of the trial, the stimulator is being turned off. And so thanks for letting us use this video. So we're looking at the speed and amplitude of movement, also looking for any tremor. And then usually we're looking at how easily can someone stand? What is their walking like, turning, balance, arm swing? And then the stimulator is turned off. And with tremor, the symptoms can return within seconds. So a nice illustration of the response of DBS in someone with tremor dominant symptoms. Now I want to switch and talk a little bit about the non-tremor dominant patients that are having motor fluctuations. So motor fluctuations refer to this phenomenon that people may notice if they've had Parkinson's for more than 5 years. They may be experiencing times when the medicine's working well, times when the medicine's not working as well. And so we call that off time, which is illustrated in the blue at the bottom, and on time, which is illustrated in kind of the gray and white of this slide. And in this slide, the bottom, the x-axis here on the bottom is time. And so the person wakes up, they're in that off state, they're taking their medicine, then it's kicking in, then they're getting dyskinesia, but they're also getting benefit from their medicine, and then it wears off, and they're in the off state again. And this cycle's happening for them, it looks like 4 or 5 times in the day. And then yellow is illustrating what's happening after DBS. So they may still have some mild off time, they may still have some very mild dyskinesia, but the bulk of their day after DBS is now this yellow line as opposed to the gray line, where most of the time is in that middle zone, not very off and not very much dyskinesia. So that's the case for DBS with motor fluctuations. And here's a graph version of it from a clinical trial that was done where they compared DBS, which is on the left side, to continuing on with medical management. And in you can see baseline and then 6 months of DBS, people went from about 6 hours of off time before DBS to about 2 hours of off time after DBS. This is at 6 months. And then they went from having a lot of time with, I apologize, it's very small on my screen. The time spent without dyskinesia increased as well. So they're having much more on time without dyskinesia after surgery. And then people that didn't get DBS were about the same over the course of the study. The bottom part is sleep. And you can see, interestingly, people with DBS did sleep about an hour more, and that's pretty common. Another way to look at the results of DBS from the same study, we're looking at quality of life. And so the dark green blue color is the people that were treated with DBS, and then the same group that was untreated with DBS that continued with medicine is that lighter color bar. And you can see that in almost all domains of quality of life that patients with DBS improve, the biggest impacts being things like activities of daily living, stigma, which is sort of like feeling embarrassed due to tremor or dyskinesia. And some areas that improved less would probably not be surprising, would be things like communication, cognition, because thinking, talking are usually not improved by DBS. So another way to look at this as we think about what symptoms will improve with DBS and what symptoms won't improve with DBS is, again, tremor, slowness, stiffness, dyskinesia, motor fluctuations typically improve with DBS. Things that typically don't improve would be things like speech trouble, swallowing trouble, freezing of gait, especially if the freezing of gait is occurring in the on-medicine state. So significant balance trouble, cognitive trouble, and bowel, bladder, blood pressure trouble would not improve. So when I have a patient in front of me and I'm trying to decide if DBS is a good option for them, I'm really trying to match their symptoms that they have and that bother them with this list here, right? To know, is this something that's likely to help you? Who's not a good candidate? As I mentioned earlier, we want to make sure it's the right diagnosis. So if it's an atypical form of Parkinson's, then you're not a good candidate. Unstable psychiatric disease. Mild depression and anxiety are very common in Parkinson's, but if it's very severe, that could really interfere with being able to undergo the surgery, and it might be difficult to tolerate the changes in medicine, because that could disrupt mood, and the DBS itself can rarely disrupt mood. So we want to make sure that that person is not experiencing unstable psychiatric disease. Dementia is an exclusion. So if someone has enough memory and thinking trouble that they have trouble carrying out their day-to-day activities independently, they are not a good candidate for DBS. And if someone has too many other medical problems, like heart disease, kidney disease, other things that increase the surgical risk, then they're not going to be a good candidate. Unrealistic expectations. Sounds weird, but I think sometimes people want to have something like DBS done because they are hoping for a cure. And that's a normal human feeling. But DBS is a treatment, not a cure. And so if people aren't realistic in thinking about the fact that this is a treatment that can help them but won't take the Parkinson's away, then they're going to be disappointed with the treatment and they're not a good candidate at that time. And then poor family support. There's a lot of appointments that go into having DBS, and people need to have somebody available to help them get to appointments and things of that nature. So what are the risks and complications? I think the thing that we really think about most is bleeding into the brain, right? So at the time the wire is placed, there's always some risk of hitting a small blood vessel and causing bleeding into the brain. That could be asymptomatic, meaning it's just detected on a post-op scan, didn't cause any symptoms, or it could be symptomatic, meaning it's causing some mild stroke-like symptoms, weakness, trouble talking, could cause severe stroke symptoms, or could be severe enough bleeding to actually put pressure on the brain and lead to death. Any bleeding of any kind is extremely rare, but that risk's never going to go down to zero, and that's why we don't just jump to DBS until we know that the symptoms are sufficient to warrant some surgical risk. Infection can occur. Sometimes that's just a local infection that clears up easily with oral antibiotics. But if the infection is more extensive and not responding well, that could lead to someone having their wires removed to prevent spread of the infection into the brain. And then the hardware could break, right? Or not work right and require more surgery to have it fixed. So limitations, I've already alluded to some of these things, that some symptoms don't improve with DBS. Some symptoms could actually be worse. So if we do formal neuropsychological testing in people before DBS and after DBS, the thing that comes up consistently on these neuropsychological tests is a reduction in verbal fluency. So verbal fluency is the ability to quickly come up with words. So many people with Parkinson's already experience this. They say, I know what I want to say. It's right on the tip of my tongue, but I can't get the words out. That can be worse after DBS. Most of the time, people don't tell us that they noticed anything being worse after DBS, but occasionally people do say, oh yes, I've noticed this and it's bothering me. Speech can be worse after DBS. I think that's less common now because of some advances in the hardware. And balance can be slightly worse as well, usually not dramatically so. And then, as I mentioned, non-motor symptoms don't typically improve. The ones that occasionally do are sleep and bladder, and then pain. So pain is a non-motor symptom. There's a lot of reasons why people have pain. But if people have pain from muscle tightness or dystonia, and those symptoms improve with DBS, then they will likely have less pain after DBS. And then it's important to realize that the DBS isn't treating the underlying disease. So what to expect if you're considering DBS, right? So the important thing is to have a formal evaluation by a team. And so I think everyone who has DBS should be evaluated by a movement disorder specialist. Again, as I mentioned, to confirm the right diagnosis, that the right meds have been tried, and determine if the person's a good candidate. Everyone should undergo neuropsychological testing. That's looking to make sure there's not significant cognitive trouble already, and that there's not some missed mood problem that hasn't already come to medical attention. And then we test people off medicine and on medicine. That's partly for our own knowledge to know that people are improving, as I said, at least 30%, but usually closer to 50%. But also insurance companies often want to see that as well as part of the workup. And then after that testing is done, people will see a neurosurgeon. And after that, we'll all meet as a team to discuss. So this is the same information in a graphical picture, again, showing the role of the movement disorder neurologist first in screening people, and then this sort of multidisciplinary team with neuropsychologists, nurses, neurosurgery, and then at the bottom, this interdisciplinary team meeting. So right now, our team meets once a week to discuss people that are in the process of getting evaluated for DBS, to make sure that we all agree this is a good candidate, and have discussion about what is the best brain target, and other details that we need to decide on before surgery. Now the day of surgery has come, right? And there's a lot of different surgical approaches. Right now, surgeons can do DBS surgery awake or asleep. So when we say awake, I think it's pretty rare, in this country at least, that people are 100% awake, no anesthesia the whole time. But when we talk about awake DBS, usually what we're talking about is someone comes in, gets conscious sedation, the kind of anesthesia that you might get if you have a colonoscopy. So you're asleep, but lightly asleep. And then you have the head frame placed, you can see in this picture. And then the surgeon makes the incision in the scalp, and then it makes a incision into the skull. And then during an awake DBS, the sedation is lightened and people wake up and talk to us, and we start to record from the brain cells to confirm that we're in the right area of the brain. And then we put the DBS lead in, and we turn the electricity on, and we look to see what is the response to the electricity. If there's tremor, is the tremor slowing down? If there's stiffness, do we see improvement in the stiffness? And are we seeing any adverse effects of stimulation? Then when we're happy with where the wire is, we put the sedation back on, and the person goes back to sleep as the surgeon is closing everything up. And that's been kind of the standard approach for a long time. But imaging techniques have improved. And so some surgeons now are doing the surgery with the person fully asleep, meaning breathing tube, stronger anesthesia. It makes it a faster surgery and less frightening for people. I don't think we know if one is better than the other, but some of it depends on each surgeon and each patient in terms of what is chosen. For everybody, though, they stay overnight in the hospital, and the next morning, generally people are feeling well enough to go home. If occasionally something isn't quite right the next day, if somebody is having a lot of nausea or headache, or something unexpected isn't going right, they may stay more than one day. But generally by the next day, people are up and able to go home. And sometimes just putting the wires in the brain, even before we've turned them on, can lead to improvement in symptoms. Sometimes that's called a lesion effect. And it sometimes lasts for days to weeks, but it's always going to go away. It's a temporary improvement that can kind of mimic some of the effects of the electricity when the electricity is turned on. So people are at home, they're generally doing most of their usual day-to-day activities, but trying to take it easy. And then a week or two after the first surgery, they have the second surgery. And that one is always under general anesthesia. That's an outpatient surgery. That's when that battery pack is placed in the chest and the brain wires are connected to the battery pack. So a second wire is added to connect them. Usually people are less nervous about that surgery because it's not brain surgery, but the recovery from that one can be a little bit harder because they are going into soft tissues in the neck and in the chest. And so there can be more pain after that. What to expect after surgery. So this is a very old picture because you can see that what they're holding here looks even older than a Palm Pilot. And then there's a wire connecting patient and the doctor. So this is what DBS programming looked like when I first started doing it. That's not what it looks like anymore. It's wireless now, and I'll show you on the next slide what the physician device looks like. But there aren't really any other photos that I could find, so I kept this one. So people are recovering at home and don't come in to have the deep brain stimulator turned on until about a month after the initial brain surgery. The reason for that is a couple things. One, we need some time for the brain to recover from the surgery. As I mentioned, sometimes just putting the wires in can improve the symptoms. And sometimes people just generally are a bit worn out from the surgery, a bit tired and not ready for to come in the office off medicine and have several hour visit as we get the stimulator activated. So the first visit when we activate the stimulator, it can be a couple of hours. It's done with medicine off. And then after that first visit, there's a period of months of trying to increase the stimulation and lower medicine until we find kind of the right balance between medicine and stimulation. For most people, they are able to lower their medicines about 50% after DBS. Some people more than that, some people less than that, but on average about 50%. And for some people, they're doing great right away after the month or two of stimulation. And for other people, it's closer to 6 or more months until we've really found that right balance between medicine and stimulation. And then once we're happy with where the settings are, then we're not seeing people nearly as often, more likely that we'd be seeing them maybe every 6 months or so to check up on the stimulator. Now, it used to be that there were no rechargeable batteries, and so people needed a new battery every 3 to 5 years. That was an outpatient surgery. Just take the old battery out, put the new one in. It is under anesthesia. But the newer batteries, so hardware has improved in the past 5 years or so, and new batteries last longer, closer to 5 years, depends on how high the electrical settings are. And there are now rechargeable batteries. And some of the rechargeable batteries are so easy to use that many people are electing to have a rechargeable battery placed at the time of their initial implant, and they will then last about 15 or 20 years. And the rechargeable batteries have to be charged about once a week or once every 2 weeks. So it's not quite as often as, say, charging your phone. So this is what the programming looks like from my side of things. These are different companies, so different companies have different interfaces, but what you're seeing in, say, this blue one, and I'm going to gesture up at the screen and apologize for those of you online who won't see this, but so this is the DBS lot lead, right? There's 4 spots where the electricity can come out, and then you can see the middle 2 are pie pieces, so they're divided into 3. Can you hear me when I step away on Zoom? Okay. So, and then what you're seeing in the other picture, the same thing. So you're seeing the four spots where the electricity can come out in the lead, and you're also seeing those colored structures. Those are some of the the brain structures that we're aiming to stimulate. And so then you can see like where the physician or advanced practice provider can adjust the electrical settings. So that's what we are doing during programming. So as once the DBS is in place, then we're moving ahead, and many times people ask, well, does DBS stop working? And the answer is no, DBS continues to work. But as I mentioned, it's not curing the disease. So some symptoms will continue to get worse. And so this is a study where they were looking at people with DBS 1, 3, and 5 years. And what you can see is rigidity, which is stiffness, was just as well controlled at 3 years as it was at 1 year, and tremor as well. But akinesia, which is sort of a lack of movement or sort of slowness, is getting worse, right, as the disease progresses. And the way I think of this is my little cartoon here. The green are things that remain well controlled: the tremor, the stiffness, the slowness. But then other things continue to progress: memory and thinking, speaking and swallowing, balance and walking. Unfortunately, continue to get worse, even in people who've had DBS. So DBS is not a cure, doesn't slow the course of the disease as far as we know, but it does improve quality of life and day-to-day activities in appropriately selected patients. So what is new? One of the things that I think has been really wonderful over the course of time I've spent working with DBS and people with DBS has been the improvement in hardware. So for a long time, there was only one company that made the device, and so they had no reason to innovate. And then other companies came along and they started to compete, and all the companies updated their hardware. And so the batteries are much more advanced now, and the wires are much more advanced. And so some of the things that are new, one is called adaptive DBS. So this has been in some of the news and people may have heard about it. But adaptive DBS means the wires that are in the brain can actually be set to be monitoring the electrical firing patterns in the brain. That's that kind of bumpy blue line that you see on the battery in the picture. And so we can set it so that if the electrical firing patterns in the brain vary out of a certain range, that the stimulator is then set to deliver more electricity. With this idea that there are probably days when you have more symptoms, and feeling worse and need a little more stimulation, days when you're feeling better, times of the day when you're feeling better and need less stimulation. And so the battery can be set to be responsive in that way. We haven't started doing this yet. It hasn't been approved. It's been approved by the FDA, but not released. And so I can't tell you yet how well this is working for people. There have been clinical trials of it. And in the trials, when people tried it for a while and then the study ended and they were given the option to continue using that feature or not, most of the people continued to use that feature. But I haven't seen studies yet that show definitively a clear-cut difference. But it's certainly intriguing and makes a lot of intuitive sense that we are humans, that our body is always fluctuating, and that it would be nice to have a device that was responsive. So that's something that we will be able to start using in the month of April. And then, as I mentioned, imaging has improved a lot, and that's helped with deep brain stimulation surgery. And so another company has developed new electrical setting, the ability for us to use a computer algorithm to look at the imaging and say, we want to steer the electricity towards this structure and away from this structure, and then come up with a complicated pattern of electrical settings using all spots of the wire to really shape the electrical field in a really precise way that's sort of customized for each person and each person's anatomy. So again, this is brand new. We've just started doing that in the past month. And so I think it's too soon to know, is this going to have a huge impact on the outcomes for people? I think it will have some impact. But ultimately, probably the biggest factor in DBS is the neurosurgeon getting the wire into the right spot, right? And then the next factor is going to be how well is the DBS set. So these new things relate mostly to how the DBS is set. Okay, so we're going to come to questions in the end. Right now, I'm going to transition to talking about focused ultrasound. So the formal name for this is focused ultrasound thalamidotomy or pallidotomy, or MRI-guided focused ultrasound, but it's abbreviated FUS. Okay. So this is something that's been getting a lot of attention as well in the press, because it is another way of performing surgery on the brain to treat movement disorders. And the first approval that was for, similar to DBS, was the first approval was for essential tremor. And later, it began to be studied in people with Parkinson's. The concept is that this is a quote incisionless surgery, meaning the surgeons are not cutting into the skull or the brain. That doesn't mean it's non-invasive, because what the surgeons are doing is making a lesion, making a hole in the brain. They're just doing it by focusing the energy from in ultrasound in a way to make a small hole in the brain. So what you see here is the team helping a patient get into this device that's attached to the MRI table, and then they're going to go into the bore of the MRI. And that's kind of what you're seeing in that cartoon as well. And so this is another way of cartoon showing you what's happening, where this energy and all these like multiple beams of ultrasound are being focused into that little point, that kind of yellow point that you can see there. And there's a lot of physics involved in this in terms of being able to bend the electricity, sorry, not the electricity, being able to bend the ultrasound beams and put across the skull. So if someone has a very thick skull or a very thin skull, it may take more or less energy to do that. And it can influence how easy it is to have a good outcome. So right now, there is FDA approval for focused ultrasound to be used to treat Parkinson's disease. The first approval came for tremor-dominant Parkinson's. And if someone is treated for tremor with focused ultrasound, the target will be the thalamus. That's the same target that's used in essential tremor, which means that only tremor would improve. We would not expect stiffness or slowness or dyskinesia to improve in those patients treated with this. But the clinical trials that have been done show that it can reduce tremor by about 50%. And the UPDRS score, which is the measure of the overall motor symptoms of Parkinson's, reduced by about 25%. So that's not very high, right? Because again, this is targeting just tremor. My worry for focused ultrasound is that there can be some permanent side effects. So in essential tremor patients, we can see side effects in about 30% of people at 1 month and about 10% of people at 1 year. The question is how severe the side effects might be, right? If it's just a little numbness, that people might be fine with that, to accept something, a side effect like that. But if it were slurred speech or worsening of balance, that might be a harder kind of side effect to accept. And so I think surgeons are still trying to figure out how to find the right balance between creating a lesion that's large enough to produce a sustained benefit, but not so large that it produces side effects, right? So the side effects come when the lesion affects other brain structures. And my worry is that people with Parkinson's might be more prone to side effects like imbalance or slurred speech than somebody like say, for example, with essential tremor, just knowing that Parkinson's already causes some of those symptoms. And because Parkinson's is a disease that gets worse, the worry too is that maybe people's symptoms are treated well for the first 6 months, but then in a year, this tremor's coming back, and then we can't easily go back and repeat the surgery. So I think there still are people who are choosing this. Maybe they just really don't want to have a stimulator or can't have a stimulator. So I think it is another tool that we have, but I don't think it's yet at a point where it's replacing DBS by any means. The other brain target that we might use to treat someone who doesn't have tremor as their main symptom is an area called the subthalamus. So it's very similar to the subthalamic nucleus in Parkinson's. So in these studies of targeting this area of the brain, this would be for someone with slowness, stiffness, dyskinesia. There was a reduction in slowness and stiffness and tremor on the side of the body that was treated with focused ultrasound. Because you can only treat one side of the body, there was not a reduction in levodopa dose. And there did seem to be some side effects in these patients, particularly an increase in dyskinesia, some imbalance, and some speech changes, as I mentioned. So again, this is available for people, and some people may choose it, but I don't think it's going to be the first go-to anytime soon. So going through a little bit of the pros and cons of each. So for focused ultrasound, the pros, the advantage is you don't have a device in you, right? So you don't have ongoing maintenance. You're not going to have to keep coming in the doctor to have your battery checked or have surgery to replace your battery. You don't face any risk of bleeding or infection. You don't have to undergo the risks of anesthesia because it's typically done awake. And you're not having to come in for visits to get it programmed. The downsides of focused ultrasound is right now it's only being used for one side of the body, because if we treat both sides of the brain, we see a lot more in the way of side effects, in particular speech and balance problems. And because we're targeting the brain from the outside rather than from the inside, it's less precise. There may be less benefit, and it's not adjustable. Advantages of DBS: more precise. We know a lot more about the long-term data. It's adjustable, it's bilateral. The downside of DBS is these risks we talked about, surgery, and need for ongoing follow-up. So my thought is that in the future, focused ultrasound will be refined. We'll have even better imaging to guide treatment, and hopefully surgeons can be able to steer away from structures that could lead to side effects, that will have a better understanding of kind of the right dose in terms of creating that right size lesion that's not too big to cause side effects, not too small to not be effective. We'll have a better understanding of whether it's safe to do a bilateral treatment. So I think more to come on focused ultrasound for DBS. And now we have time for questions, so I'm going to stop sharing so I can see everybody.
If you could open up your chat.
Yep. There's some questions in there.
Yeah, we're not going to open audio on the chat.
Okay, so the first question in the chat is there a correlation between DBS improving tremors but affecting fall risk? I don't think there's necessarily a correlation, meaning like the more benefit you get, the more side effects. I mentioned that there could be that could occur in focused ultrasound, where you're making a bigger lesion and where you're getting more benefit and therefore more side effects. In DBS, if a lead is well placed, we should see good benefit without much in the way of side effects. With DBS, there is an adjustability factor, and so if a wire was not in exactly the right place, then you could imagine a scenario where you're turning the electricity up to improve the tremor, But once you turn it up, then you're having some spillover of the electricity into an area that controlled balance, and then you're seeing more balance trouble. So Caitlin, if I didn't answer your question, send another chat message. Can we have a copy of the slides? Thank you for asking, and stay tuned from Connie for more information on that. Other questions? Yes.
It talks about so DBS benefit tremor. But what kind of tremor? Like, it's a tremor associated with dystonia, just different.
So just to clarify,
cause the tremor.
Yeah, just to clarify, DBS does not treat only tremor. So many people who have DBS don't have any tremor with their Parkinson's. Tremor, I think, is an easier thing for people to understand because, like I said, DBS can improve tremor even if it's not responsive to medicine. And then the majority of people who have DBS done for Parkinson's may not have tremor or may not have tremor as their main symptom. But those patients are people who have motor fluctuations, times when the medicine's working well, times when the medicine's not working as well. And the DBS is placed to try to improve the number of hours of, quote, good time or on time and lessen the amount of off time. But to answer your question about tremor, we're usually thinking of kind of classic resting tremor in Parkinson's that occurs when the limb is not being used. And that's probably the most common type of tremor that we're talking about in Parkinson's.
Does that treat dystonia?
Yes, so dystonia can be improved with DBS, especially if it's most of the time dystonia is an off medicine phenomenon. So like when the levodopa dose is low in the body, people get dystonia. Occasionally people can have dystonia as a symptom of dyskinesia, and that would also be improved with DBS.
So the DBS surgery does improve dyskinesia,
Correct.
and it is recommended if we have a lot of dyskinesia.
So there's a lot of different ways to improve dyskinesia, but if someone's having dyskinesia and we try to lower the medicine dose and then they have too much off time and we can't find that middle ground between dyskinesia and off time, then that could be a reason to have DBS.
Now, the other question I have is the other surgery that you were saying that they don't go into the brain, is that a one-time surgery?
The other surgery I talked about is called focus ultrasound.
Right, focus ultrasound.
And that is done, it's a one-time thing. So you come in the morning, go home, it's outpatient surgery, and the results are present as soon as you leave.
And you don't have to come back 6 months later and do it again?
Correct.
Hey, Dr. Zauber, a lot of people that I talk to and a lot of the support groups that I work with, there seems to be a fantasy about DBS doing away with Parkinson's. And I know you talked about that. And one of the things that's brought up again is the medications. Oh, I don't have to take medication anymore. There's just a lot of rumbling going out there. Parkinson's is not curable in our lifetime right now. DBS is just working on symptoms that we might be able to tolerate. Could you speak a little bit more to the medication portion of it after DBS?
Yeah, I mean, I'm looking around the room here and I know some people here had DBS and don't take any medicine. And I know some people here had DBS and do take medicine. And I think that it does vary a lot from person to person. A lot of it depends on the individual patient in terms of, and some of it depends on what brain target we choose. So some brain targets have, as I mentioned, there's the globus pallidus and the subthalamic nucleus are two different brain targets, and there's different reasons why we might choose one or the other. For some people, medication lowering is a goal and it's needed for some reason. And for other people, medication lowering isn't the goal. The goal is better symptom control. But you're right. Certainly DBS is not a cure. And so it is important for people to be to be aware of that reality. On the other hand, it's also important for people to realize that it's not a last ditch treatment, right? So this isn't something that people should put off until the very end of their course of disease with Parkinson's. This is a middle of the disease treatment. So I think that message has gotten through to some extent. We're seeing people pursuing DBS at an earlier age, earlier stage of their disease. It used to be people would wait 10, 15 years into the disease when they had already kind of had to drop out of working, dropped out of a lot of their roles in life because of the unpredictability of their response to medicine. And now people are saying, if DBS is safe and effective, why am I going to wait? Why don't I do it sooner? And we're seeing more people having surgery between the 5 and 10 years of disease. So I think, yes, be aware that it's not a cure, it's a treatment, but also don't be afraid of it if you're the kind of person whose symptoms would benefit from it.
And you also said that we don't do it here in the States, you made that statement, but if you're 70 and over, usually the board's gonna say, nah, he's too old, or she's too old.
That is true in some parts like Canada and Europe. Sometimes, perhaps with nationalized healthcare in those countries, they are a little bit more strict in choosing people. But that's not the case in the US. But I think when we think about motor symptoms, non-motor symptoms, things like memory and thinking changes, balance and walking, people over 75 are much more likely to be experiencing a lot of balance trouble, a lot of memory and thinking problems due to Parkinson's plus age-related changes. And so that's another reason why they may not, their symptom profile might not fit as well with the symptoms that respond well to DBS. Yes.
Yeah, I think in the slide they talk about it needs a lot of support from your family. What kind of why is so, and what should we expect the support or family support?
Yeah, great question. So if someone has absolutely no one, that could be a red flag for having DBS. That does come up every once in a while, but usually somebody has at least a child who lives maybe out of state but can come in around the time of surgery, or friends who can, friends or family members who can pitch in if they are single and don't have a partner. A lot of it is coming in off medicine for some of the appointments, having somebody to be with you after you're discharged from the hospital. So you're going to be able to do your day-to-day activities after the brain surgery, but we don't like to send people home from the hospital alone after brain surgery. We want somebody to be with them in case they're not feeling right. Somebody to be around for a couple of days or weeks after the surgery, somebody to help drive to appointments. Those are the kind of things that we'd be looking to see. Yes, hi.
Comment and a question. The deacon at our church had been diagnosed years ago, 12, 15 years ago, and he recently went through DBS. I think he's about 60 years old. His first operation was in September, and I thought he said it was in September. I thought he said his second one wasn't until December. With that said, though, he said it is incredible. He said he has a whole new life. He says at one time during the last number of years, he was taking, have you ever heard of this? 28 pills a day. That's wow.
Yeah, so to get back to your comment, the way we do it at IU, we are typically doing both the right and left side of the brain on one day. And then so that's the first surgery. And then the second surgery that we do is where the battery pack is placed. And that's a week later. If this person you mentioned had a second surgery a few months later, it may be that that surgeon chose to operate on one side of the brain and then wait a few months and operate on the second side of the brain. So that's something that different surgeons may do. We haven't had a habit of doing that at where I work, but there are a few centers that choose to do it that way.
Some of the things that you said remind me, I have sleep apnea and I have Inspire
Mhm.
in me, just under the skin, which is what this would be.
Yeah, so the stimulators are used in a lot of other diseases. So I don't know if people online could hear, but I'll try and repeat the questions. I apologize. I should have been doing that. Somebody mentioned they have Inspire, which is a stimulator for sleep apnea. So that's not a brain stimulator, but it's a tongue a stimulator for the nerve that controls the tongue. And there's also things like spinal cord stimulators for pain and bladder stimulators. And so stimulators are used pretty widely in medicine these days. Yes,
One more.
sure.
Misdiagnosis, can you say a few words about that?
Misdiagnosis. So I don't think it happens I mean, I don't think people that are coming to see me for DBS are frequently misdiagnosed, but occasionally somebody doesn't have Parkinson's disease, but may have, as I mentioned, one of the more rapidly progressive disorders. Probably the thing that mimics Parkinson's the most is something called multiple system atrophy, because multiple system atrophy occasionally can respond to levodopa, but people start to develop motor fluctuations much earlier in the course. They require much higher doses of medicine, and they develop a lot more significant autonomic changes and balance problems. So those are, those diseases can actually be made worse by DBS. And so that's why we try to make sure that we're not treating the wrong thing. Yes.
Two questions. Can you talk about the typical side effects of levodopa? And then, do you do research, and could you comment or characterize on the research that's being done at IU and nature of any clinical trials and such?
Sure. So side effects of levodopa, when people first start on it, they can develop nausea. Usually that's mild and transient, but occasionally nausea is severe enough that it limits someone's ability to take the medicine, and we have to be creative in trying to medicate with certain anti-nausea medicines or try different forms of the medicine. And then constipation sometimes is made worse by carbidopa levodopa. People can develop low blood pressure from carbidopa levodopa. Some of that, low blood pressure can be part of Parkinson's disease due to the autonomic nervous system changes. So many times if someone had hypertension, then if they've lived with Parkinson's for a while, they end up with normal blood pressure, go off their blood pressure medicines. But the carbidopa levodopa further lowers blood pressure. Dyskinesia is a side effect of levodopa, but it's important to know that it's also part of the disease, the dyskinesia. So if you gave levodopa to someone who doesn't have Parkinson's, they would never get dyskinesia. So dyskinesia is kind of the involuntary movements that can occur, kind of twisting, swaying type of movements. The risk of dyskinesia is related to how long someone's had Parkinson's, how severe their Parkinson's is, and the dose of the carbidopa levodopa. It's not related to how long you've taken carbidopa levodopa. So there's not a timer.
So is it eventually going to cause you to have dyskinesia?
The disease causes dyskinesia eventually, right?
Not the medication.
Right, if you don't take the medicine, you won't get dyskinesia, but you will have other problems. So yeah, I don't think anyone should be afraid of dyskinesia and put off taking carbidopa levodopa. I think that's a feeling that people had for a long time,
But
and I'm seeing less of that now, fortunately. But you can't escape dyskinesia by not taking carbidopa levodopa, in the sense that I've had people develop dyskinesia right away because they waited for 10 years before starting their carbidopa-levodopa, and then they had dyskinesia right away. So it was the disease severity, the disease duration, not how long they've been.
I
on
take it,
levodopa.
it keeps me level, but I've read several books that said that it could cause dyskinesia. And, you know, and it's in the writing there in
Correct.
these Parkinson books. And it does make me think about it, and I'm fearful of it. So I'm always, am I shaking, it's in my mind that it could cause it. Because the book told me that.
Yeah, there's a subtlety to it. Like I said, if you didn't have Parkinson's and you took the medicine, you wouldn't get dyskinesia, but the combination of medicine and Parkinson's can lead to dyskinesia. Most of the time, people who have dyskinesia aren't aware they're having it. And it doesn't bother them a whole lot, but occasionally it is bothersome to people, and then we need to adjust medicine or do other things to try to manage it.
Now, when a person has dyskinesia and it's really bad, you're saying that they don't know they're doing it?
Sometimes that's the case, yeah. You had another question, and
Research for clinical trials?
yeah, so we don't have a large number of clinical trials going on currently at IU. We're hoping to increase the number. Some of that was sort of staffing shortages during COVID, and we don't have enough movement disorder docs currently. But we do have a genetic study that's going on where people can get free genetic testing with Parkinson's. The reason for that is that different people who carry certain genes may have a faster or slower course. And because there are clinical trials happening around the country, and probably more that will be coming soon, that are giving certain drugs to people who carry one gene versus people who carry another gene. And so I think I apologize that I didn't, I do have a list of a number of different projects that are going on, but I don't have it right in front of me right now. So we do have a number of things that are going on from a research standpoint, but I think when people are thinking of clinical trials, they're thinking of, can I sign up to try and get an experimental drug, and that we don't have right now.
Thank you.
Right, out of respect for everyone's time.
It looks like I missed some of the ones in the chat. Do you want me to
Well,
answer
I think
or end here?
we'll go ahead and end here. We do record the chat questions. I can follow up with you and get some responses
Sure.
there, but
Sure.
out of respect for everyone's time that needs to drive home in rush hour traffic and folks that do need to leave, I'm gonna go ahead and hit the stop record. I will share this presentation through Rocksteady and our YouTube channel. You will all get free access to the presentation. And with regard to the research, Dr. Zauber can share that information with me. That is part of my job, is to communicate what's going on in research with our Rocksteady community. So you can find me on the webpage or just down that hallway if you come to our gym. But I'm free to answer your questions and follow up here in any way that I can. So thank you, everybody who is online. Yeah, where's the mess? Where is it?
Thank you, Dr. Garland.
Thank you, Dr.
It was a recorder that just gave me last year. Wrote it on my paper about it. Right up there. I can send them, just send it to me. She did a nice summary.
Oh, yeah, I did.
Oh, thank you. Now I have a worry flash drive.
That's right, that's important.
Hey, Dr. Garland.